Okay, we're going to go ahead and get started, everyone. Welcome to Patients Rising's Midday Masterclass. We're going to be talking about 340B today. 340B, we're going to be putting it in focus, not for, from a patient perspective. We're going to talk about the history, the impact, the state, what's happening in the States, which is a lot. We have some wonderful panelists here today to join us to talk about this. So we're going to go through each 5 different sections as we kick this off. And then I'm going to introduce everybody also to our soon to be launched Patients Right to Know campaign, which is a campaign that Patients Rising is going to be doing specifically around 340B in the States and sort of what our plans are for that. And then we'll open it up for questions from everyone towards the end. So I'm going to go ahead, and we have a lot to cover. So I'm going to go ahead and get started. First, I'm going to introduce you to, many of you probably know, Bill Smith from Pioneer Institute and Robert Popovian from Conquest Advisors and many other Global Healthy Living, all of his many places that he is connected with. But we're gonna just use Conquest Advisors today. So as we kick it off, I'm going to, here we go. Bill Smith, Robert Popovian, and Bill, I'm just going to dive right in, because this is one of the things that we want to talk about first is sort of setting this up, because, what is 340B? Because as I've always said, for Patients Rising, as we've talked about this, it's like we haven't really dove into 340B all that deeply, because to me, it sounds like a tax form. And so it's been a very difficult process to kind of figure out, okay, how are we going to engage patients? And what we came to the conclusion of is we just need to engage patients and educate them with things like this, because otherwise they're not going to know. And there's so many facets of this that can support patients and help patients that they should know. And so with that, I want to kick it off. So what is 340B, Bill?
Uh, Thank you, Terry. Thank you for organizing this. And I'm just going to go through a couple slides and try to explain at a 30,000-foot level what 340B is. And then in my second slide, I'm going to try to point out how the program has gotten really off track from its original goals, which were quite noble goals. 340B is sometimes described as the 340B drug discount program. That is somewhat deceptive in that it is not a discount program for patients. Patients don't get a discount card, the 340B card that they could use at the pharmacy to get a discount. It is not a discount program for patients. In fact, I think that's one of the biggest infirmities in this program is the discounts that hospitals and clinics get on their drug purchases are not passed on, nor are they required to be passed on to patients themselves. The background on this is that in the 1970s and 80s, there were a lot of safety net hospitals and some clinics that treated a lot of the uninsured. Medicaid was a very small program at that time. A lot of patients that came into these safety net hospitals did not have insurance, and the hospital would have to eat the costs of treating them. So pharmaceutical manufacturers decided generally that they should give discounts on the purchases that these safety net hospitals made to help them financially. And it was voluntary. The manufacturers did it on their own. There wasn't a law passed or anything like that. And they gave safety net hospitals really deep discounts, and which the safety net hospitals appreciated and used the extra revenue to treat uninsured patients. Then in 1990, Congress passed a reconciliation bill that said manufacturers have to give Medicaid the lowest price of anybody, any customer that they have in the United States. That created a problem for the voluntary discounts that were being given, because those prices that were deep discounts were going to have to be passed on to all 50 state Medicaid programs. So the hospitals themselves were concerned they were going to lose these discounts. So they went to Congress and they said, please, Congress, don't destroy these discounts. In fact, require them. And so in 1992, Congress created the 340B program that required drug manufacturers to give these deep discounts to certain hospitals and clinics that serve a lot of low-income patients. And generally, there are a lot of categories of clinics and hospitals that can be eligible, but the biggest category for hospitals is if you get 11.75% of your patient base as Medicaid, you're eligible to join the 340B program. So that the Congress thought Medicaid patients, if you're treating a lot of them, you're probably in a low income area and you're treating a lot of low income patients and uninsured. So that's that requirement. Let's go to the next slide, and I can explain really why this program generally went off track.
Yeah. Let me go back over here. Sorry about that, Bill. There we go.
No, that's all right. So the bullet on the top left is really the one you should pay attention to, because in the beginning, this program worked quite well for about a decade. And then suddenly, a lot of hospitals discovered that they could arbitrage the discounts that they were getting. What does that mean, arbitrage the discounts? It's a Wall Street word. It means if you want to make a big profit, buy low and sell high. So how do they do that in the 340B program? Well, they do that. They say the average price of a new oncology drug is about $200,000 on average, according to IQVIA. But if the hospital can buy that drug at a very low price, say $25,000, and then they can bill Medicare or a commercial insurer when the patient comes in who has good insurance, they can bill $200,000 for that particular drug. They can pocket $175,000 profit on one prescription. So that's what's happened. They're arbitraging the discounts, and they're buying low and selling high, which made the program go off track, to be honest, because this creates an enormous incentive for them to treat fully insured patients or well-insured patients, people on Medicare, people that have good private insurance. It doesn't provide any incentive for them to treat the uninsured or people who are going to pay cash for their drugs. So that's, in my mind, where the program went off track.
And Bill, we've seen some bills. We've seen some actual patient bills like that, where you'll look up what they were charged for the medication, which the list price will be, $6,000. This is not a cancer drug. I mean, not an oncology drug, but the list price of the drug was $6,000, and what they were charged was like $27,000.
Yes.
On the, so they also do it that way too. There's like, they won't even just charge. They're so bold that they charge way over even what the list price is.
Yeah, and many of the patients that come in don't even know they're eligible for potential discounts. They don't know the hospital has gotten a discount on the drug, and the discount is not passed on. So an uninsured patient could be charged full price by the hospital. That doesn't happen in every hospital, but it happens a lot. And so what's happened with this program is, because there's so much cash flowing into this program, for-profit PBMs and pharmacies have globbed onto it, and they've gotten into this program, and the 75% of the pharmacies and PBMs are for profit that are participating in the 340B program. Another thing that's happened, which Kathy can talk about later, is that this is an incentive for hospitals to go out into wealthy communities in particular and purchase physician practices like oncology practices or rheumatology practice, because if they can get those patients to come in the door, chances are they're going to have good insurance, and they can arbitrage the discounts. And there's been uncontrolled growth in the program. The program last year had sales of $124 billion at list prices. So by 2026, this will be the largest federal drug program. It's not some small minor program. And the bottom right slide is really the most troubling, is as this program has grown and revenues into the program have grown substantially, charity care for 340B hospitals have been declining. They've been giving less free care. They've been treating fewer uninsured patients. Now, part of that is due to the fact that Medicaid has been expanded and more patients have insurance, but nonetheless, there's still 40 million uninsured people. So hospitals could, if they really reached out, treat more uninsured. And with that, I'm going to turn it over to my colleague, Robert Popovian, who's going to talk a little bit about how you can learn more about the 340B program, as well as what's happening on the state level.
Thank you, Bill.
Thank you, Bill. There you go.
Thanks, Harry. So what Bill and I decided about 3 years ago is that we needed to create a tool that was transparent for anyone to be able to access and really look at the growth of this 340B program on their own, whether it's a policymaker, patient, provider, hospital, whoever is involved in the healthcare system. So the whole premise was to look at the growth from a perspective of contract pharmacies. And one of the things that Bill talked about is this changing of the definition of who could be a covered entity, but at the same time, through ACA, they also removed the cap in the number of contract pharmacies each covered entity can have. You know, initially you could have only one contract pharmacy. That cap was removed. And because of that, there's been a significant growth in the number of contract pharmacies as well as covered entities over time, as he mentioned. So we decided to create this tool. Initially, we started looking at just the proliferation of the contract pharmacies in different states, where they're located, whether it's in state, out of state. Then we started looking at a legislative map from from a state perspective. So these are legislative districts for the House and Senate on the state side, and looking at whether or not how many contract pharmacies are in those areas, who are those contract pharmacies, as well as how many hospitals and clinics that qualify for 340B. The last piece of the puzzle came about 2 years ago. We decided that we wanted to include charity care data in the database so people could see, like Bill mentioned, what is the level of charity care that these hospitals are providing that are 340B eligible. And so we purchased the data from RAND Corporation. The reason we did that instead of using the CMS data is because RAND has been sort of following this topic for over 2 decades at least. And they've been cleaning up the CMS data. And Bill and I, basically, when we bought the data, we didn't realize they collect about 1,700 data points from the hospitals that are regarding a lot of different things, including charity care. And so I'll talk at the end that we're about to relaunch this website. It will probably be done within the next couple of weeks. We have a big event coming up in DC on Thursday after Thanksgiving that we're going to talk about how this is going to be a new look. We're going to put more data, and I'll talk about specifically what that data will look like. Terry, can we go to the next slide?
Sure. Yep. There you go.
So when you go on the Pioneer website, on our website, what you will see is various levels. This is one example of the pharmacy growth nationally and specifically in the state of Michigan. So for example, in the state of Michigan, you can look at how many contract pharmacies are in the state of Michigan, not only serving Michigan hospitals, but also how many of those contract pharmacies are out of state, not necessarily in the state of Michigan. And you can even look at individual hospitals. For example, the top hospital with the most contract pharmacies is the University of Michigan Hospital Association. You can click on that and you could see specifically how many contract pharmacies for the University of Michigan are in state versus out of state. This is one of the arguments that Bill and I and everybody else has been making in state houses when legislation comes, is that we question why there are so many contract pharmacies, but why are there so many contract pharmacies out of state for these patients? These are not affluent patients that travel or anything else. But what you notice is a lot of hospitals. I know Bill has worked a lot in Michigan. I have testified both in Missouri, in Oregon, and in New York. I've worked with the legislators in New York State. One of the questions I always bring up is that why so many contract pharmacies, why so many contract pharmacies out of state? Just give you an example, in another state like Oregon, Oregon Health Sciences University is the largest institution in the state. 44% of its contract pharmacies are out of state. And they could never explain why this is going on. So this is sort of, our website tries to shed some light about contract pharmacies and their locations. The next slide, please, Terry. As I mentioned, we also collected the charity care data from RAND Corporation. And what we can do is look at charity care data on national level that the hospitals provide based on their operating expenses, and then individual hospitals within the state and also state averages. So for example, in Michigan, the average charity care for a hospital in Michigan is well below the national average. with regards to how much the charity care they provide. One of the things that we're going to add to this next iteration of the database when we launch it is going to be, we are going to be able to tell how much of that charity care was provided for insured versus uninsured patients. So that level of data is going to allow us to make the argument, because a lot of times what you hear from hospitals is that we're taking care of all these uninsured patients. The reality is a lot of these hospitals are providing charity care, quote unquote, based on their own data for insured patients. They're not uninsured patients. So we're going to be able to put that sort of caveat in there and show people, okay, for example, University of Michigan, what percentage of their charity care went to insured versus uninsured patient, which raises a whole other set of questions, Terry, which is underinsurance in this country, which is what happens to the billions of dollars of rebate dollars that goes to Medicaid, and Medicaid doesn't really provide the services that the patients require. It's a bigger question about our healthcare system and benefit design that's going on.
Absolutely. Absolutely. And what about in this, Robert, when you're talking about the charity care piece, and I know you talked about all of the contract pharmacies, and then and then Bill was talking about there's, Medicaid discounts, there's, 340B discounts, and all of this, now the program is so large. Is there, how does that work? I mean, is there any accountability there?
It's going to get even more complicated, because according to the Inflation Reduction Act, there's this Inflation Reduction Act discounts on certain MFP drugs, right? So, and which the pharma companies are required, they're required to actually flag those and make sure that there's not duplicate discounts like happens with Medicaid right now. So it's going to get far more complicated. That's why you see a lot of the discussion, what happened with what Johnson & Johnson wanted to do, which is go more of a rebate system, which is to, okay, you send us the confirmation that you filled the prescription for a 340B patient, then we will pay you the rebate back instead of upfront discount that right now hospitals are getting. Obviously, there was significant pushback from the hospital systems, but also Congress, as well as HRSA. J&J backed off, but as we saw last week, there are lawsuits now filed against HRSA, because really, if you look at it, it's not about just duplicate discounts on Medicaid. This IRA is going to have duplicate discounts involved in it also. And really, by law, the pharma company is required to flag those and make sure that they're not doing the duplicate discounts, that the Medicare is getting their fair share. So what happens now? There's going to be lawsuits.
So they're required to do the duplicate. They're required to be accountable to make sure it's all happening, but the other side is not, doesn't.
Right. And CMS has floated this idea that they're going to create this clearinghouse system that's going to do it, but really they haven't done anything about it. They've just floated the idea. And, I think this is going to be interesting to see how the courts decide, because really the responsibility falls on the pharma companies to do this. So one of the things
sorry.
No.
Did you want me to change?
No. Change it.
No, not yet.
Because we can
Change
talk
it. Okay.
about this. Yeah, that's fine.
Okay.
One of the other areas that we've looked at is that where are these pharmacies within the states located? Geographically, are they located in rich neighborhoods or in poor neighborhoods? And we're able to do that now too. And in fact, we were adding this data to our web tool. We were able to do it in the background, but anybody can look at it. We can take House districts or representative districts in the states and look at the poverty level of those in those districts, and we can tell which pharmacies are in which districts, and therefore we can say, okay, pharmacies are either in high end or high income or low income. And what we see regularly in almost all the states, that these pharmacies are in affluent neighborhoods. They're not in poor neighborhoods. And you see this consistently over and over again in every state you look at, is that the majority of these pharmacies are in well-to-do neighborhoods. And if you think about it, theoretically, they shouldn't be at all, right? Because these patients don't live in those neighborhoods. They're living in more poorer neighborhoods. Finally, I know we don't have a slide on this, but this is an important issue. When you look at contract pharmacies, whether it's on the national level or a state level, what Bill alluded to is that this is being taken over by big pharmacy chains and for-profit chains, as well as PBM pharmacies. What you see over and over again in the state level and on the federal level, on the national level, is that the top pharmacies with the most contracts are PBM owned. So when states are passing laws to really protect or sort of like hinder or obfuscate any kind of transparency, what they're doing is basically doing a big favor to the PBMs because they're the ones that own all these contracts. This is not about the mom and pop, you know, Terry Wilcox pharmacy down the street who is trying to help in the community. This is about big business. The top pharmacies nationally, the first three are Walmart, and then after that, every one of them is PBM owned pharmacy. You know, so again, we're creating an environment, we've created laws and regulations that really benefit big business, but benefit big PBMs. And they're not helping patients or even independent pharmacies. And for some bizarre reason, when we go and work in the state level, you see the independent pharmacies running around trying to, you know, again, support like lack of they don't want to support transparency and everything else. And my question is, you're not the ones that are benefiting from all of this work. It's the PBMs that are making more money. And guess what happens? Same thing happens with those physicians that Bill talked about, and Kathy's going to talk a little later. Same thing happens with the independent pharmacies, and it's been already documented in the FTC report. They go and buy these independent pharmacies, you know, and they put them out of business. So again, this is big business, big corporations that are leading it. Next slide.
So can I ask you one, can I
Sure.
ask you one question that just came up, which I think might be good in this spot, because I just think it's one of our, she's asking, why are insurance companies not motivated to challenge this pricing on the drugs? So is their answer just to
It
raise
used to be.
premiums, or is it something more sinister?
No. It used to be, right? So the insurers,
Right.
actually, the plan sponsors, so-called plan sponsors, used to be the gatekeeper, right? For the 340B program, they didn't want this to go out of control because what Bill talked about is this arbitraging system. They were ending up paying for these high expensive drugs and not getting the discounts. Well, that went out the door about 4 years ago, 5 years ago, right? With the vertical integration of insurers and PBMs. They're one and the same. The plan sponsor and the PBM is the same entity. So when the PBMs say that they're passing on the savings to the plan sponsor, they're basically passing it from one hand to the other. So there's no differentiation and there's no gatekeeper anymore to look over and make sure that there's no corruption in this model because it's to their benefit for these PBMs to make money on the 340B program, just like they do on rebate contracting and things like that. They no longer care because they make money. And if you, Terry, if you look at almost every single vertically integrated insurer PBM, what you notice over and over again is that the PBM is the profit center for those entities. So yes, the insurance company, the insurance side makes money, but really, if you look at the profit center, is the PBM business. So insurers have close their eyes and letting it happen, and there's no gatekeeper anymore watching over the penthouse. Any other
Amazing.
questions? Any other questions?
That was one I just, that we're gonna have more questions at the end for
Okay.
people, but that one I thought was relevant to where we were, so I just went ahead and.
So
Okay.
next slide. And Bill, you want to take this because this is your wealthy American.
Sure. This is really an explanation of how I believe the program has gone off track. Because hospitals can buy drugs at very low prices and get reimbursed by Medicare and commercial insurer, this provides an enormous incentive for these hospitals to bring in fully insured and wealthier patients, such as Medicare patients or patients on expensive commercial insurance. And this has spurred hospitals to locate their satellite sites, their physician practices, and contract pharmacies in wealthier areas, closer to the fully insured patients. And the desire to serve wealthier patients has led to a dramatic decline in charity care spending, even as 340B sales have skyrocketed. And lastly, to make you even more cynical, a recent study suggests that the hospitals that have joined the 340B program after 2011 serve just enough low-income Medicaid patients to qualify for the 340B discounts, but then they don't bring in more. So they reach that 11.75% threshold of Medicaid patients. They qualify for the discounts, and then they don't bring in more Medicaid patients or low-income patients. So it's a program that's way off track, and it's now serving wealthier Americans rather than low-income Americans.
Terry, one thing to add to the Bill's comment, because you can find it in our website, is that you can also see how these institutions, these hospitals qualify to be a 340B entity. And what you notice is that some of the largest institutions in this country, it's not even about the Medicaid. They qualify as rural entities, rural hospitals to qualify. So one of them is Cleveland Clinic, I believe, that qualifies as a rural hospital, which makes no sense. And they don't have to take a single Medicaid patients, and they could still be considered a covered entity because of the rule changes of how they qualify.
Yeah, Mass General, the big flagship Harvard hospital in downtown Boston, qualified for 340B as a rural referral center, as a rural hospital. I mean, you can't make this up. And it's largely because they couldn't get to the 11.75% Medicaid threshold. Mass General serves about 8% of their patients as Medicaid patients. So they had to find another way to get the discounts. And they somehow figured out how to qualify as a rural hospital.
That's amazing. Wow. So when you're talking about, is there another slide after this, guys? Is there another? Okay.
That's it. Yeah.
Just so but Bill, I want to ask you before we move on to Calvin here in just one second. Where is this Pioneer? We're going to send out an email after this is over that'll have a link to this this session, this webinar, and then we'll also have some other links in there. Is it pioneerinstitute.org/340B abuse? Is that
Well, if you go to
where do they find this?
Terry, if you go to the pioneerinstitute.org website, right in the center, you'll see a 340B.
Okay.
Click on that and you'll get to our tool.
Okay. Okay, great. I just wanted to give a shout out for that because I was going to put it on the slide and I forgot to. Okay, up next, we're going to talk to Calvin Pugh. Calvin is a consultant with the Community Access National Network, CAN, and he's going to give us an overview of, these qualified, the community health centers and Ryan White clinics and sort of their perspective on 340B. And so let's kick it off. First of all, Calvin, how did you get involved with CAN? Just introduce yourself.
Hi, everyone. My name is Calvin Pugh, and again, I'm a policy consultant for CAN. I got involved with CAN through ADAP advocacies, fireside chats, and being part of their 340B community advisory council, which is a group that started about 2 years ago to educate patient advocates on 340B and why it matters and what's going on behind the scenes, including some of ADAP Advocacy's great work on uncovering some of the executive increases that have happened in these hospital systems and in some and some of the grantees too, that you see an increase in their massive executive pay or bonuses that happen instead of providing charity care.
Now, from a patient perspective, in your view, what is most misunderstood about the 340B program and its impact on care in the settings that you...
Go ahead.
I just said in the settings that you work in.
Yeah, I think, for any of us, patients or patient advocates or patient groups, all of us work in a space where we care, where, it doesn't have to impact us that it should matter. But in the case of 340B, it really does impact most of us. One of the clear things is 340B is a vital source of income for federally qualified health centers. These are the clinics like the one down the road from me currently that I used to work in. This is providing vital care to communities who can't necessarily afford to pay the overinflated prices of a hospital system, and provide access to services. When we're thinking about health equity and how that access point is part of health equity. So when you think about a clinic that someone can get on the public transportation to, or easily accessed, especially for those who are underinsured and or uninsured. Like Bill was saying about, community oncology clinics, places where, a cancer treatment might be hours away from someone in a rural city, a rural place, or a smaller city, not right in the city center. And then when we think about things like Ryan White or the AIDS Drug Assistance Program, which is the only grantee named in the 340B legislation, we're talking about life-saving treatment for people who are living with HIV and AIDS, and access to those services in places where maybe that's not as accessible. And we think we've come a long way in the last 47 years of the HIV epidemic, but the grantees and the benefits of 340B to ADAP programs and Ryan White is essential for helping us create a level playing field in that fight for health equity. I mean, if that's not
Um,
enough, oh, go ahead.
oh no, I was just, no, you finish your sentence. I
Oh,
was
yeah.
not a big, um, I was just going to point out one of the things that we just had heard from obviously Bill and Robert, and about all the sort of not transparent things that are occurring on the hospital side for the 340B hospitals. But one of the things that I always like to point out about the grantees, the Ryan White clinics, the federally qualified health centers, and others, is that they actually have to report on what they do with their money for funding from 340B on a quarterly basis. And yeah, so I just, they're already struggling to keep their doors open and to serve everybody they have to serve. And they also have to do this reporting, and they do it. So, anyway, I wanted to put that in because I think it's important.
It is important because you think about the transparency that's required of these federally qualified health centers and things like Ryan White. There is a demand on them being able to access these funds to actually ensure patients have access to the healthcare that they need, that hospitals are not, and these larger healthcare settings are not being required to do. And if you go and look at the ProPublica, which is a new fascination of mine, of the hospital systems reporting of their 340B income versus their charity care percentage, I mean, it is truly wild what the revenue these places are making. I mean, you think about it's ballooned over the last several years, especially in light of COVID. you know, those hospitals and grantees really did buy $66 billion of medicine at a discounted rate. And that's according to HRSA, which is 24% of an increase in 23 as opposed to 24. But in comparison, patients and insurers, their total net spending on medications only grew by 5.6% over the last 5 years. So there's very little evidence that those savings are reaching those of us who are utilizing hospital services, or, and more importantly, the vulnerable patients that it's meant to serve.
Well, I would agree with you. I mean, if you talk to our friends at $4 who completely focus on helping patients with charity care in hospitals and other folks like that, it has, they aren't being held accountable, and they aren't, when you look at Michigan, as they said, as Robert and Bill pointed out, it's 0.7% charity care, whereas the national average is 2.29. And then to add insult to injury, the for-profit hospitals have a higher level of charity care than the nonprofit hospitals who are enrolled in 340B. So I just think I've always find it that you guys are able to, not you personally, but the grantees are able to keep up with that paperwork that the giant large hospitals with all this money have told us, and that is an administrative burden that they cannot manage. So I just, to be able to just report exactly what you're doing with the funds from this program. So what work has CAN done specifically in advocating around 340B in the States and other places? I know you guys you had 340B What About Me campaign and some other things. So do you want to talk a little bit about that?
Sure. Yeah. So last year, at the end of last year, they launched the 340B What About Me campaign, which is there was a video and ad that went out across the internet, which features a lot of advocates. There's a clip of me climbing indoor on a rock on rocks, asking 340B What About Me. But it asks, when hospital executives are pocketing this cash, or they're using it to build fountains and waterfalls inside of facilities, calling that, patient access. Uh, what about the patient? What about, those of us who should be benefiting from these discounts that they're getting, but they're not passing those along to us? And in the opposite direction of that, many of these hospitals are charging patients and sending them to medical debt for full price of those medications, if not an increased price. There's a staggering amount of medical debt in this country. So CAN has launched the 340B program. They've also done some billboards with a couple of us, especially around legislative jurisdictions, right around offices, um, poking the bear a little bit to see if we can get the legislators to uh, go with the right way. There's a lot of pressure from these hospital systems on our legislators to do things that they want to push back against transparency, and to, when you have our partners in the industry trying to ask for more transparency, the hospital associations are getting these bills passed through the states. We also have, parallel to what Bill and Robert were sharing about online resources, we have our 340B Action Center, which features the videos. It also features some really easy to access patient knowledge fact sheets about each state, but also about the program as a whole, which we're going to update here shortly. There also is, we have similarly state pages, but they make the legislation that's happening currently trying to prohibit, majority of them trying to prohibit pharmaceutical companies from limiting what drugs are able to be accessed by these hospitals in, who are asking for more transparency. So we have quite a few states up now, but there will be more added as there's a long list.
Well, no, that's great. Well, and like I said, everyone, we'll have a lot of these links that we're talking about when we send the follow-up email. We'll put those in there, and we'll also have them on our own 340B website, which I'll show you at the end. Thank you so much, Calvin. I really appreciate it. Now we're going to move on to Kathy Oubre. Here we go. Do I have the right screen up? Okay, sorry about that. Hi, Kathy.
Hey,
How are
Terry,
you?
how are you today?
I'm good. So now we're going to talk about the 340B campaign, or not campaign, but 340B in general from the provider perspective. And I'm just curious how just as a broad overview, because we have a lot of patient advocates on here too, and they may not really understand that connection, because we always talk about the hospitals, right, directly. But how does 340B actually affect your day-to-day operations when you're talking about, cancer clinics and community oncology centers and things like that? Can you give us sort of an?
Sure, and it's a great question, and as Calvin and Robert and Bill alluded to earlier, this is also becoming an issue around health equity, financial toxicity, which is impacting patients across the nation. And even though it is a federal program, it is having a large impact in all 50 states. And so, why is it becoming a state issue? Because most states have state employee health plans. And a lot of these health plans are are in the 340B entities. And so the states, due to lack of legislation on a federal level, the states are starting to take a look at how the program's affecting them, their overall budget, and that just trickles down to patients. And I believe, Bill mentioned it earlier, and I'll get to a finer point about it later. But what we are seeing is medical debt increasing with some patients, and we're seeing access problems, as Calvin, alluded to earlier. So, if you guys will bear with me for a few minutes, I'll tell you a story about why it's becoming a state issue, drill down into some of the finer points, and then how it's impacting, our our friends and our families and the patients that we serve in these areas. So in May of this year, the North Carolina Treasurer published a report looking at 340B usage and abuse within the state. And why did they do that? Because in 2025, the state employee health plan, which includes teachers, firefighters, emergency workers, they are facing a $32 billion windfall. And they don't have a lot of, avenues to kind of fix that from a budgetary perspective. So they were faced with three choices. They needed to find areas of meaningful cost control to provide price relief for the patients as well as the plan. Either that, or they were going to need to find money somewhere, which also meant perhaps raising taxes within the state. So that becomes a taxpayer issue for every citizen within that state. Or lastly, reducing benefits for everyone in that health plan and also raising premiums and deductibles. So the state embarked on this research. And what did they find? They found widespread abuse of the 340B program in their state health plan. So just from a nuts and bolts perspective, so Wake Forest, which is one of the larger health systems in the state, they found that they were charging the state health plan about $3,500 for a drug that they were purchasing for $500. So you take that multiple, and they're charging that state health plan so much more, and they're able to buy it at a very steep discount. And Bill mentioned that earlier. The pharmaceutical manufacturers are required to sell these drugs to these hospitals at, maybe a 40 to 50% discount. But that discount there's nothing in statute that requires that discount to be passed down to the patient. And very often it's not. It's kept at the entity level. And then it's up to the entity on how they want to reinvest that. It's supposed to be in charity care and community investment. But as Calvin mentioned earlier, community investment can be redefined in lots of different ways. So there's
Waterfall in the lobby.
yeah. You said it, not me. But
I don't actually know if there's a waterfall in a lobby, but I have seen some elaborate lobbies before. So I just. Yeah.
And then how is it also impacting, patients within a state? Medical debt. So North Carolina looked at the medical debt within their state, and they found it to be quite high. They also found that the 340B entities were engaging in rather aggressive medical debt collection practices. So when a patient would go into the facility, they would encourage them to sign up for a medical credit card with, an average interest rate of about 18 to 22%. And then in 2020 to 2022, North Carolina sued 7,500 patients within the state who had been into a 340B entity. So there's that as well. And let's talk about medical debt, because that's a health equity piece. So, the AMA did a publication very recently that found that, medical debt is much more common in about 60% of people in medical debt are people of color. And then of that 60%, 20% are experiencing medical debt that's in a collections standpoint. So, and keep in mind, these are all patients that have been through a 340B entity designed with a program that is supposed to care for them, not put them in collections. So let's be very clear about that. This is becoming a financial toxicity, and this is impacting families. So even if one patient is experiencing that debt, then the whole family experiences that debt. And then they're making choices perhaps between paying those bills and their mortgage or their food bill. So this is having broad-ranging consequences in all of the communities that we live in. So, so there's that piece. Also we're experiencing medical service and pharmacy deserts. And this has been brought up before. So in our neighborhood, in our area, I have 3 clinics in the state of Louisiana. 1 is in the wealthiest parish in the state. 2 are in the bottom quartile. And in one of those areas, our wealthiest parish has 3 340B entities. And what they do is they will then they develop child sites, and that's allowed by law, as well as the contract pharmacies, and those extend their reach all over the area. Now, you can also have access deserts. So there is an area in Virginia, in Richmond, Virginia, Richmond Community Hospital, which was, founded almost a century ago in a predominantly Black area of Richmond, was acquired by a health entity called Bon Secours. And what
Right,
they
yes.
did over a period of time, and most of us are familiar with this, is they started draining the resources of Richmond community. So they closed the ICU. They didn't necessarily replace equipment such as a CT scanner when it broke. And what they did over time is they took those funds coming in through Richmond and they invested them, of course, into the wealthier areas of that community, which has a higher percentage of commercially insured patients. So if you go back to that arbitrage, which Bill, mentioned earlier, you buy low, you sell high. Well, that makes much more sense if you're going to maximize that thought process in a wealthier area. But what that did to Richmond community and the residents of that area is it robbed them of resources and access. So by closing the ICU, not replacing the CT scanner, they also lost a lot of their physicians because the physicians didn't have the services needed anymore to even care for the patients in that area. So they left as well. So then patients didn't even have the basic needs of a physician to care for them. So then it was driving them to other child sites in the wealthier communities. But that Richmond community area doesn't have well-established public transportation. And so then they were looking at, having to get to those child sites that might be up to a half hour away without access to public transportation. So then, you have just patient access issues.
Yeah, the Bon Secours story really fascinates me. I mean, I live in Virginia, that it isn't, that people aren't more enraged and incensed about it than they, it really does, because I thought it's incredibly impactful, and it's in a bad way, because of what has occurred.
Yes. No
And
doubt.
so I think it's sort of a microcosm of what's happening and what we know is happening all over the country.
Yeah.
Right. And we have it here in black and white.
And I know we only have a few minutes left, so I won't get into it right now, but I will mention to you all, and it's completely my fault. I didn't get these to Terry till yesterday, but I did put together a list of questions for patients, as to ask if you're going to a 340B entity. And then I also put together a whole host of questions for those of you who want to get involved with your state or your federal legislators around 340B legislation. So I'll be sending those over to Terry today, and I believe she's going to be putting those up on the website.
Yes, I'm going to put those up on the website, and I'm also going to put them I know we have a lot of our patient senate and our patient advocates who've listened to this today and registered, and they're very interested in that. So like I said, I'm going to be making it into a document to add there. Now, last but not least, I want us to talk to Demisha Montgomery. She is a patient advocate, and she is also a member of the Patients Rising Board, and she's also the president of what we call our Patient Senate, which is our body of sort of super advocates, I call it. So she's been really great and very interested in the 340B program as we have developed what we're doing which is the Patient Right to Know campaign. And first of all, I want to just do one thing that I didn't do. There she is. That's your picture at the fly-in. So tell us a little bit, what should patients know, Demi, or what do they not know about the 340B program? I mean, when you're thinking about advocating on this and we're thinking about talking about this, like what jumps out at you the most? What?
That this is even happening. This is alarming to me that this is happening, and that as a patient that we don't know that these are even out there. I had no idea that charity care was even an option. For me personally, my husband isn't insured, and we have took on medical debt due to not even knowing this existed. So for me personally, I think that a lot of patients definitely need to be educated on what 340B is, how it works, and how we can advocate for ourselves. The one thing that I think we need to know is in the moment that we are visiting any medical facility, how do we advocate for ourselves right there on the spot so that we don't get into the situation of being sent to a creditor? Is there something specific that we can say to them to make sure that we are receiving all of the services that they have? So I didn't know if any of you guys would be able to kind of speak on that.
I can speak a little bit to that just from our work with $4, Demi. And you were on our webinar, our town hall that we just did recently with $4. And $4, for those of you who don't know, is a website that specifically helps patients who have medical debt try to resolve it. And a lot of times it involves charity care at hospitals, because obviously most medical debt is hospital debt generally, because there's not anything else really that'll let you, hospital and doctors, but there's not anything, for medicines and things like that, you have to pay for it before you can get it. So this is, definitely it's all in that space. But one of the things is just to straight up ask. And one of the things that we're doing, this segues nicely into what we're doing with the Patient Right to Know campaign, is we really want patients to start to ask, am I a 340B patient? Is that a thing? Like we know. And I have a bunch of questions here, which we're going to get to in just one second. So everybody, I know I'm going as fast as I can. But, we think that patients have a right to know, number one, that the program exists. Are they being tagged 340B? Because the reality is nobody knows. And to your point, to everyone's point on here, it's not always the people that should be tagged 340B, if there's such a tag at all that anybody can see, because it's not transparent, right? So, what is that? What is that? And how are there any benefits available to me? I think one of the number one things that we're encouraging patients to do and patient advocates to do, especially if they're in a situation where they're at a hospital, if it's a 340B hospital or otherwise, and you can look up whether your hospital is a 340B hospital. You can also, and if it's not, even if it's not, I want to talk about charity care. Every hospital has charity care of some kind. And so when you're talking about charity care, you should always, ask and be, find out about that. Sometimes they don't tell you about it. I found it very interesting. My mother-in-law was just in the hospital for a month, and we got a bill, I don't know, 2 weeks ago, I finally got the bill. And inside my bill was this whole thing about the charity care we could now apply for. They've sent me the bill now, and then I had this like one sheet if we wanted to apply for that, which I thought was interesting. You would think it would be the other way around, like while the person is there, they would sort of vet whether or not they were qualifying for charity care 340B, et cetera, et cetera. So no, your reaction, Demi, is the one that we have gotten from every patient that we've talked to, and you were very involved in helping us get patients to go to Illinois and talk with legislators there and share their stories. So we're going to be doing a lot more of that. And before we close out today, I just wanted to I'm going to just go down here and ask a couple of questions and let you guys, take your shot. So in California, Governor Newsom changed how Medi-Cal providers bill for 340B drugs under his Medi-Cal RX initiative. Do you have more information about that and how it may impact 340B? Do you have any insight into that, Robert? You live in California.
Well, partly live in California. So, but one thing did happen in California this last election cycle. There was a ballot initiative that is going to force 340B entities to spend money regarding healthcare, like only on certain things that they cannot basically, they have to disclose. There's going to be an auditor that looks over to see what they're spending the money on regards to 340B discounts. So that ballot initiative did pass overwhelmingly in California. So it's clear to me that people want transparency. The patients want transparency, population wants transparency. I'm not really aware of this, the Medicaid thing, but it has quite tied to this issue regarding the ballot initiative.
So another question, state officials and hospitals will argue that some 340B entities are academic medical centers, which caters to patients across the country. And that is the rationale for large contract pharmacy networks. What do you say?
I say that is not true, because if you look at it, their argument is, well, all of these pharmacies are mail order pharmacies that are out of state. But there was a JAMA article that came out about 2 years ago that showed that about 90% of these contract pharmacies are brick and mortar. They're not actual mail order. So that falls flat. I think if you look at one of the things that we didn't talk about is that the lucrative contracts that these contract pharmacies get for dispensing a 340B drug, it's not your typical dispensing fee that a pharmacy will get from a typical dispensing of a medicine, which is between $15 to $20 depending. It's 20% of the cost of the medicine, the WAC price of the medicine, plus a dispensing fee, which ends up being, we've calculated like a $7,000 drug, ends up being about $1,100 in fees that the pharmacy gets for dispensing that $7,000 drug. So it's a very lucrative dispensing fee. So that's why the expansion of the contract pharmacies and why they want to keep going.
Gotcha. So are patients paying copays on discounted 340B price and the list price charged to payer, or the list price charged to payers? I guess we don't really know. It depends on the plan, depends on so many factors. That's part of, that's part of the transparency issue, is that we don't know. We don't know that. And it's hard to know that.
Okay, we do know with co-insurance and deductible, patients pay off of the list price. So
right.
We know that.
Yeah, on private. Yeah, that's true. On their insurance plan, it generally is.
Yeah.
So
that's irregardless if the drug is a 340B discounted drug or a drug that's been PBM has negotiated savings on.
Gotcha. Did you want to say something, Calvin?
I was just going to reiterate what I was saying. What I was going to say, what Robert just got there, was that it doesn't matter, regardless of whether the drug was purchased for a 340B discount or not, they're still paying the co-pays and and sometimes going into debt on things that have, been discounted at 340B. which is seems criminal.
So I have what I think is a good question here, which is why should patients care about this program if covered entities are the beneficiaries of the discounts, not the patients? Well, I think that's sort of the point in many instances, is that patients don't know. And it's actually, yes, the covered entities are the beneficiaries, but Robert, I remember talking one time, you have a really interesting, like, why can't the discount, at least, of somebody being tagged 340B follow the patient in some way? I mean, is that too complicated?
It should, right? That's the logical way of doing things. Unfortunately, the way that the statute is written, Bill and I have talked about this when we've done briefings in DC with the Hill staff. The statute is written very poorly. It basically creates the language is that it doesn't define a patient. What it defines is an institution. And unless that statute is changed and a patient definition comes about, you're not going to be able to change the model to where it should be. It's the same issue. Like, look, food stamps is a good example, right? Patients get individuals get food stamps, not the grocery store. You don't walk into a Kroger's grocery store and have everybody getting food stamp like discount or something. Individual consumers get it. So same thing should apply to the 340B program, but it doesn't because of how poorly written the statute is.
Absolutely. Okay. Guys, I just am going to tell you, you guys asked a ton of great questions, and I'm sorry that we have quite a few. I'm just going to ask one more, and then we'll close out. I'm going to try to get the other ones answered in the follow-up email. I'm going to download this and copy all of that to make sure that we get all of these done. But I guess my final question I'm going to ask is, can you speak to how the increase of 340B rebates or discounts disrupt state Medicaid rebates, and what the double rebate prohibition is? Can you kind of just touch on that?
I can touch on that, Terry.
Okay.
I mean, there's in the federal law, it outlaws duplicate discounts, meaning you can't get a Medicaid rebate on a 340B drug, which already gets a discount. And the reason they put that in there is because if Medicaid rebates are so generous and 340B discounts are so steep that if you combine the two, manufacturers would be essentially giving away the drugs for free. So this duplicate discount problem, though, creates a Medicaid rebate revenue issue for states. So if a patient comes in and gets a 340B drug, the state can't get the Medicaid rebate. So they might be losing Medicaid rebate revenue because of 340B.
Gotcha.
And Terry, this issue of IRA puts this problem on steroids, basically, because it introduces the MFP drugs the same way that duplicate discounts are going to happen on the Medicaid side. So the federal government's going to lose discounts if they don't capture those patients, right? And they go to the 340B discount.
Exactly. Well, I have one final question, which I'm going to answer, and then I'm going to close this out, which is, what, if anything, can we as consumers do to prevent the hospitals from price gouging? I was like, I don't exactly think there's anything we specifically can do. We can't force them to do anything. They already are supposed to post their prices from their charge master on their website in some really strange format that most of us can't read, unless we have the special software of which you can decode that. I think part of it is demand. I think part of it is awareness. One of the things that Patients Rising that we talk about a lot is taking agency over your healthcare and your choices and your knowledge. This system is complicated, no matter how you look at it, whether you're on, Medicare, Medicaid, Veterans Affairs. I mean, we have a bunch of health systems that are all, make up our giant healthcare nut in this country, as far as like what we spend on healthcare in America. And I think the more that we educate consumers and patients to know that, the better. They'll have to do better. Eventually we demand better, they do better. And that's part of it. You'd have to sort of, transparency is important. Sunshine is the best, disinfectant, as they always say. And so I am a big proponent of that. And that's sort of the focus of the campaign that we're going to be doing. So the rest of these questions, I'm going to try to answer individually to the folks who asked them, or I'll put them in the follow-up email. Some of them are people that are in our community. I'll post them there as well. But I want to thank everybody for joining us today. Thank you for giving us an extra 6 minutes of your time for those of you who could stay. And like I said, the recording will be coming out shortly. Thank you, everyone.
Thank you.
Thank you.
Thank you. Stop. Recording.